Dr. Chabalani, one question I have in community is, do we think bone scans are obsolete? Do we need to use bone scan as a treatment, even just on somebody who is metastatic, hormone-sensitive or castrate-resistant prostate cancer? Do you use that for periodic imaging response on a CT or a bone, or you usually just do CT scan and only use bone scan as needed?
I mean, that's a great question. As we've been talking about, PSMA PET has completely revolutionized the field in every stage of prostate cancer, from localized to metastatic castrate-sensitive to metastatic castrate-resistant. And I do think there's this gray area that Dr. Kelly and Dr. Wong have alluded to, where a patient is presenting with a PSMA PET scan and there's like disease in a lot of different bones, and is this high volume, or is this not? Is this like low volume? Is this less than 3 actual mets? Should we be radiating the prostate, as like there's an OS benefit to radiate the prostate and low volume disease, metastatic castrate-sensitive disease. So I think when there's these like kind of mets everywhere, but they're low SUVs, and I'm worried about false positives, then I do go ahead and order like a regular CT chest abdomen pelvis and a nuclear medicine bone scan, because from our trials, that's where we have the data for how to treat low volume versus high volume disease. On the other hand, if this patient's presenting to me with a PSMA PET scan that's showing clear liver mets or lung mets and visceral disease, then I'm not going to bother to put them through additional testing. And at that point, I'm thinking probably like triplets versus doublets, docetaxel intensification, versus not, on the backbone of ADT plus ARSI. Because a lot of these patients they're coming to us, they've been seeing many different providers, and it's like 3 months in, and they're like, I just want to start on a treatment now. Do I have to get more imaging? So really, it's the nuanced cases where I'm like, is this high volume or is this low volume? Should I be radiating the prostate as well, or should I not? Or where I'm ordering the CT chest abdomen pelvis and the bone scan. And then, after patients have had their initial treatment after 3 to 6 months, and their PSA has gone down and it's nice and low, that's when I feel comfortable. Let's just get the restaging CT chest abdomen pelvis and bone scan. Let's get a new baseline. Insurance isn't going to argue with me, and then we have this new baseline that we can continue to follow. And as long as their PSA is staying nice and low, like every 6 months or 6 to 12 months, I'll just keep ordering that CT chest abdomen pelvis and bone scan. But then if the PSA starts to rise again, and I'm worried about castrate-resistant disease, I go ahead and order the PSMA PET, because as Dr. Wong was talking about, now we have a chance for SBRT or metastases-directed therapy, and if this PSA rise is just being driven by 1 or 2 spots, then we can maybe keep the patient on the ADT plus ARSI backbone and radiate 1 or 2 spots. So I think, yes, PSMA PET has revolutionized the field, but we still need to be using CT and bone scans in some scenarios, because that's what our trials that tell us how to treat patients have done in the past. But in the future, I think bone scans will probably become obsolete a few years from now.
Sure.
I agree. I think the thing I really hate with bone scans is trying to use them to assess response and looking at serial ones, because you have flare. If you look at the prostate cancer working group criteria, it's really only either there's a complete response or you have this progression and there's flare. And PSMA PET, even we know from the Australian study with cabazitaxel versus lutetium PSMA that the PSMA PETs are very good for predicting survival in the cabazitaxel group. So even for a non-mechanism based therapy, and just eyeballing those scans, maybe I'm wrong, but I feel much more comfortable. Sure. I know it's going on, looking at them, and once I get a PSMA PET, then I can compare apples to apples by ordering them, and thankfully insurance hasn't caught on to me yet, but maybe they will soon. So I think that covers the imaging issue. Again, kind of in the background as we hear the data from these trials, these were both, the trials we're talking about were all done before PSMA PETs were part of the standard assessment.
And so Len, as the now prostate cancer group, is the trials are now in the future using PSMA PET as a marker for response, or they are still struggling to decide what is the right endpoint for the trial?
I think they're still wrestling. I think I know that there are trials ongoing now where radiographic PFS by CT and bone scan are one of the primary endpoints. I know there are trials that are including PSMA PET, including, I believe, some registration trials, but has it become part of an accepted endpoint for, let's say, a surrogate for survival even?
Sure.
I would say, my understanding is not yet by the FDA, and we don't really have the data yet to show that.
Thank you.